Peripheral neuropathy. Definition: disorder of peripheral nerves resulting in impairment of its function, which may be sensory, motor, or autonomic. Classification: according to the number of nerves involved and according to the type of nerves involved. According to the number, we have mononeuropathy, affecting single nerve in one limb, mononeuropathy multiplex, affecting more than one nerve in one limb, polyneuropathy, peripheral nerves affection in all limbs, systemic disease. According to the type of nerves involvement, pure motor neuropathy, pure sensory neuropathy, autonomic neuropathy, and mixed neuropathy, more than one type. Causes of mononeuropathy: infective, leprosy, herpes zoster, vascular, polyarthritis nodosa, metabolic, diabetes mellitus, and other systemic diseases that usually start as mononeuropathy, traumatic, wrong injection into a nerve, and the commonest cause is nerve compression such as carpal tunnel syndrome, median nerve, cubital tunnel syndrome, ulnar nerve, neck of fibula, common perineal nerve. Causes of polyneuropathy: heredofamilial such as hypertrophic interstitial polyneuropathy, Refsum's disease, peroneal muscle atrophy. Infective: viral, cytomegaloviral virus, mumps, measles, bacterial, diphtheria, typhoid, tetanus, leprosy, Lyme disease. Nutritional: vitamin B1, B6, B12 deficiency, metabolic, diabetes mellitus, uremia, porphyria, and amyloidosis. Toxic: inorganic and organic alcohol and insecticides, inorganic all heavy metals such as lead, arsenic. Endocrinal: acromegaly, myxedema. Immune: rheumatoid arthritis, polyarthritis nodosa, systemic lupus erythematosus, scleroderma, and Guillain-Barré syndrome. Iatrogenic: INH, cycloserine, sulfasteroids, metronidazole, vincristine, anti-AIDS drugs, and antineoplastic drugs. Neoplastic: leukemia, lymphoma, multiple myeloma, localized tumors as gastric and lung and hepatic tumors. Miscellaneous such as celiac disease and Fabry disease. Clinical picture: it may result in one or more of the following manifestations. For motor, we have weakness of lower motor neuron nature, hypotonia, hyperreflexia, and wasting. Distribution: bilateral, symmetrical, affecting distal more than proximal, extensors more than flexors, lower limb more than upper limb. Signs and symptoms related: starts with muscle cramps, twitching, and weak grip, foot and wrist drop, weak extensors, hyperreflexia starting distally, lost ankle with preserved knee reflex, high steppage gait due to foot drop. Cranial nerves may be affected, especially CN3, 6, 7, 10. And finally, sensory symptoms: pain, burning sensation, paresthesia in limbs, followed by hypoesthesia or loss of sensation, starting distally and progressing proximally with time. Signs: superficial sensory affection occurring distally, such as gloves and stocks nature, deep sensory loss distally, and loss of deep reflexes due to loss of sensation. Autonomic: we have cutaneous and vasomotor. Cutaneous: loss of hair, brittle nail, trophic ulcers. Vasomotor: calmness, cyanosis of limbs, fainting, and postural hypotension. Dryness of eye and mouth, disturbed neurogenic bladder, gastroparesis, delayed emptying and digestion, constipation and diarrhea may also occur. Disturbance in sweating, whether increased or decreased. Blurred vision and unequal pupil size, erectile dysfunction, and silent myocardial infarction may occur. Treatment of peripheral neuropathy: treatment of the cause, whether diabetes mellitus, infection, nutrition, toxins. Care of limbs, trophic changes, ulcers, and infections. Physiotherapy if weakness is apparent. Pain control: tricyclic antidepressants such as imipramine for burning, throbbing, and aching pain. Stabbing pain: anticonvulsants such as carbamazepine, gabapentin, or pregabalin. Flow modulators: Trental. It improves microcirculation of the brain by increasing the RBC's deformability and decreasing platelet aggregation. Capillary modulators: calcium dobisilate, vitamin B complex, B1 100 mg daily, B6 200 mg daily, B12 1000 microgram daily. Diabetic neuropathy develops in 50% of the patients with long-standing uncontrolled type 1 or type 2 diabetes mellitus. Both myelinated and unmyelinated fibers are involved. Pathogenesis such as we explained in endocrine. Diabetic macroangiopathy, hypovitaminosis due to polyuria, production of toxic ketone bodies, nerve damage, or increased production of sorbitol and others, leading to cell injury in nerves and vessels. Clinical picture: same as peripheral neuropathy but with special behavior. It begins as mononeuropathy affecting sciatic, femoral, ulnar, median nerve, or cranial nerve 3, 6, 7. Then polyneuropathy develops. Sensory and motor, mainly sensory, as motor affection occurs late. Generally, it starts in lower limb, then later it involves the upper limb. Also, deep sensation is early lost, loss of deep reflexes and sensory ataxia. Muscle sense is first increased, differential diagnosis of tender cuff muscles, then it's lost. Large fiber involvement or posterior column, vibration sense is lost early, loss of joint sensation resulting in Charcot joint, fine touch, deep senses are also lost at later stage, which is called diabetic pseudotabes. Treatment such as peripheral neuropathy, but with strict control of diabetes mellitus, Charcot-Marie tooth disease or peroneal muscle atrophy, heredofamilial peripheral neuropathy which appears during the first or the second decades of life, mostly caused by defects or mutation in genes responsible for peripheral myelin protein. Clinical picture starts in first and second decade of life with gradual onset, very slowly progressive course, wasting and weakness in lower limb involving peroneal muscles, anterior tibial group, up to the lower third of the thigh, giving specific appearance called inverted champagne bottle. Later on, upper limbs becomes involved, distribution, distal more than proximal, extensors more than flexors, associations, weakness, foot drop, high steppage gait, wasting, pes cavus, high arched foot, due to atrophy of intrinsic muscle of the feet. This marked degree of wasting is associated with mild disturbance of motor power, sensations impaired, especially vibration sense, and may be associated with hereditary ataxia. Then we have acute infective polyneuropathy or Landry-Guillain-Barré syndrome. Acute fulminant polyradiculopathy of autoimmune nature, cellular and antibody mechanism, usually preceded by infection, etiology, and pathogenesis. 2/3 are preceded by GIT or upper respiratory tract infection, usually for 3 weeks, such as Mycoplasma pneumoniae, Haemophilus influenza, cytomegalovirus, Campylobacter jejuni, Epstein-Barr virus. Then the other third is immune response to non-self antigen, infectious agent, and vaccines misdirected to host nerve tissue due to molecular mimicry. Clinical picture: pre-paralytic stage, febrile stage, latent stage, paralytic stage. Febrile or pre-paralytic stage starts by upper respiratory tract infection or GIT infection remaining for 2 to 3 weeks, giving constitutional symptoms, fahem, and other symptoms specific for the infection. Latent stage, patient is free for 1 to 4 weeks. Paralytic stage starts as acute, rapidly progressive, usually ascending lower motor neuron affection, weakness, hypotonia, hyperreflexia with or without paresthesia, foot, leg, thigh, trunk, respiratory, and chest muscles. This may need mechanical ventilation, upper limb, cranial nerves, facial and bulbar symptoms, distribution proximal more than distal without wasting, it occurs late and to a little extent, tender calf muscles and severe back pain usually present early in the disease, sensory involvement may occur, glove and stock, and deep sensory loss, autonomic involvement, cardiac arrhythmia, hypertension or hypotension may occur, prognosis 80 to 85% show spontaneous complete recovery in 2 to 3 weeks, 5% die of respiratory involvement and lung infection, 15% recover partially with residual neurodeficit. Diagnosis is mostly clinical, CSF analysis in first week, cytoalbuminic dissociation, cell count from 10 to 100 per milliliter, and protein 100 to 1000 milligram per deciliter. Variants of Guillain-Barré syndrome: Miller-Fisher syndrome, triad of ataxia, areflexia, ophthalmoplegia, pharyngocervicobrachial pattern, acute oropharyngeal palsy, flaccid paraparesis variant, pure sensory variant, acute pan-dysautonomia. Treatment of Guillain-Barré syndrome: disease-modifying treatment and supportive treatment. Disease-modifying treatment: immunoglobulin IVIG treatment of choice. The dosage is 0.4 gram per kilogram per day for 5 days. Plasma exchange and plasmapheresis for exchange are sufficient for moderate to severe diseases and presentation. Combining the plasma exchange and the IVIG doesn't show additional benefit. Supportive treatment: complete blood rest till recovery, bulbar muscles, frequent suction of pharyngeal secretions, neostigmine 1 mg hourly, intramuscular tube feeding in case of pharyngeal paralysis, respiratory suction of secretions, adequate ventilation and oxygen support, antibiotics for respiratory infection, tracheostomy may be needed, control of arrhythmias, thromboembolic manifestations, low molecular weight heparin, TED stocking for DVT prevention, neuropathic pain, gabapentin, carbamazepine, bowel function regulation as constipation occurs due to immobility and drug side effects, vitamin B complex, intramuscular daily, physiotherapy essential early to prevent contractures and later during rehabilitation, including massage, passive and active movement, exercise, positioning, and electric stimulation. Leprotic neuropathy: Mycobacterium leprae is characterized by granuloma infiltrating nerves and causing thickening, thickening, degeneration, impairment of functions. Clinical picture, mainly sensory, mono or polyneuropathy, affecting nerves such as lateral popliteal, ulnar, greater auricular, trigeminal, and facial nerves, characterized by irregular thickening of nerves. Neuropathy can occur with the three types of leprosy, whether lepromatous, tuberculoid, or mixed type. Treatment: patients are usually treated for 2 years by multiple drugs, dapsone, rifampicin, and diphenhydramine. Diphtheric neuropathy. It's common and occurs due to release of exotoxins by Cyanobacterium diphtheri. Clinical picture: localized type, generalized type. Localized type starts 3 to 4 weeks after infection, affecting cranial nerve 3, 7, and 10th nerves, developing dysphagia, dysarthria, hoarseness of voice, blurred vision due to impaired accommodation, lost palatal and pharyngeal reflexes. Generalized type starting 2 to 3 months after initial infection, numbness, paresthesia, and weakness of arms, legs, and occasionally respiratory failure, mainly motor. Treatment: antidiphtheric theorem, 100,000 units intramuscular, and antibiotics with cardiac support. Pellagra, multisystem disorder due to vitamin B complex deficiency, special niacin or nicotinic acid. Etiology: decreased intake, decreased absorption, increased demand, or drugs. Drugs such as methotrexate, phenytoin, trimethoprim, increased demand such as pregnancy, dialysis, cirrhosis, diabetes mellitus. Decreased absorption, gastrectomy, diverticulosis, achlorhydra, pernicious anemia. Decreased intake, old age, starvation, or food with low content of niacin or its precursor, tryptophan. Clinical picture: cutaneous manifestations, GIT, and neuropsychiatric manifestations. Cutaneous bilateral symmetrical dermatitis followed by hyperkeratosis, desquamation, and pigmentation. Site: exposed areas or over bony prominences. Gastrointestinal manifestations: mouth, stomatitis, glossitis with atrophy of papillae, glazed tongue, stomach, dyspepsia, epigastric pain, intestine, colic, and diarrhea. Hepatosplenomegaly may be present. Neuropsychiatric manifestations: peripheral neuropathy, mainly sensory, para or quadriplegia, systemic paraplegia due to pyramidal degeneration, pellagra, lateral sclerosis, mentality changes, anterograde amnesia, depression, dementia, suicidal tendency due to cerebral cortex degeneration. Treatment of the cause: proper intake, plus vitamin B complex, plus iron for anemia. Nicotinamide 500 mg IV daily in severe cases, after improving 200 mg daily for 2 weeks, and maintenance dose 100 mg 3 times per day orally. Subacute degeneration, subacute combined degeneration, vitamin B12, cyanocobalamin deficiency. Clinical picture: it's represented by triad of megaloblastic anemia, GI manifestations, and neuropsychiatric manifestations. Megaloblastic anemia: pallor, fatigue, palpitation, dyspnea. GI manifestations: stomatitis with red, smooth, swollen tongue, beefy tongue. Stomach: dyspepsia, nausea, vomiting, achlorhydra. Intestine: colic and diarrhea. Neuropsychiatric manifestations: combined degeneration of peripheral nerves, pyramidal tract, and posterior column. Peripheral neuropathy: pain, paresthesia in limbs, followed by stock and glove hypothesia, plus lost ankle reflex with preserved knee reflex. Pyramidal degeneration resulting in weakness in the limbs with positive Babinski sign. However, the tone and deep reflexes are diminished due to peripheral nerve and posterior column lesions. Posterior column degeneration leading to deep sensory loss or sensory ataxia. So you have to remember that despite having weakness in the limbs with positive Babinski sign, we have lost tone and deep reflexes, and it's due to posterior column region and peripheral nerve. Treatment of the cause: vitamin B12, we give 1000 microgram intramuscular daily for 2 weeks, then 100 microgram twice per week. Beriberi, thiamine or vitamin B1 deficiency. We have dry beriberi, peripheral sensory neuropathy, wet beriberi, congestive heart failure, and cerebral type vernix encephalopathy, amnesia, ophthalmoplegia, nystagmus, and ataxia. Treatment: thiamine 100 mg daily, vitamin B complex, diet rich in vitamins and low in salt, digitalization with diuretics in case of heart failure. Differential diagnosis: causes of motor neuropathy: we have porphyrium, lead neuropathy, diphtheric neuropathy, and acute infective polyneuritis. Causes of sensory neuropathy: diabetic neuropathy, alcoholic neuropathy, vitamin deficiency neuropathy, arsenic neuropathy, leprotic neuropathy. Causes of tender calf muscles: DVT, Landry-Guillain-Barré syndrome, myositis, and early diabetic neuropathy. Causes of second nerves or hypertrophic neuropathy: amyloidosis, myxedema, acromegaly, neurofibroma, leprotic neuropathy, Refsum's neuropathy, interstitial hypertrophic peripheral neuropathy. Causes of lost ankle, preserved knee reflex, epiconus lesion, coda equina lesion, peripheral neuropathy, subacute combined degeneration, Friedreich's ataxia. And this concludes the peripheral neuropathy. Now we're gonna go to myopathy. Muscle disorders characterized by gradual, progressive degeneration of group of skeletal muscles without involvement of the nervous system. Causes: we have inherited and acquired. Inherited progressive dystrophy, and it's classified into 4 types: muscular dystrophy, myotonic dystrophy, channelopathies, and metabolic or McArdle syndrome. Muscular dystrophy, shoulder or pelvic girdle. Myotonic dystrophy, myotonia congenita or myotonia atrophica. Channelopathies such as periodic paralysis syndrome due to potassium imbalance. Myotonic phenomena recently included. Metabolic or McArdle syndrome, very rare. Myophosphorylase deficiency or mitochondrial disease. Acquired: we have inflammatory, endocrine, metabolic, and drug-induced and toxic. Inflammatory: viral, bacterial, or parasitic infections. Connective tissue diseases and overlap syndrome, rheumatic arthritis, SLE, Sjogren syndrome, polymyositis, dermatomyositis, and inclusion body myositis. Endocrine myopathies: Cushing syndrome, Conn's syndrome, acromegaly, thyroid diseases. Metabolic myopathies: liver failure, chronic renal failure, and renal tubular acidosis, debilitating diseases, and periodic paralysis syndrome or potassium imbalance. Drug-induced or toxic myopathies: inflammatory necrotizing rhabdomyolysis, inflammatory cimetidine, penicillamine, prokinamide, necrotizing chloroquine, colchicine, and cholesterol-lowering agents. Rhabdomyolysis: alcohol, heroin, amphetamine, cocaine, and cholesterol-lowering agents. Clinical types of progressive muscular dystrophies: we have shoulder girdle types such as Erb's and Landuzzi with Digerine. Pelvic girdle type: Leiden-Mobius and Duchenne and Becker. Other rare types: distal type of Gower, ocular type, oculopharyngeal type. Clinical picture of hereditary muscle dystrophy: onset: it starts from the first to second decades with gradual onset, progressive course. Symptoms: clumsy gait, inability to climb stairs, difficulty on rising from sitting position, protuberant abdomen, weakness and wasting of certain muscles. Signs: we have weakness, deformities, pseudohypertrophy. Others: pseudohypertrophy present in certain cases such as Duchenne and Becker, mainly in gluteus maximus, quadriceps, calf muscles in lower limb, deltoid, supra, and infraspinatus muscles in upper limb. Others: we have facial muscles are bilaterally weak in certain cases such as facioscapulohumeral type, which is Landuzzi and Digerine. ECG changes and cardiomyopathy may be found especially in Duchenne type. Deformities: later on, fibrosis and contractures of affected muscles, skeletal deformities, Piscavis and Talipes equinus. And then we have weakness involving skeletal muscles, especially trunk, shoulder, pelvic girdle muscles. Lower motor neuron nature: wasting, hypotonia, hyperreflexia, but no fasciculations and no trophic changes. Distribution: bilateral, symmetrical, proximal more than distal, shoulder, arm, forearm, and hand in this order, thigh, leg, and foot. Selective atrophy of sternal head of pectoralis major with preserved sternomastoid and preserved clavicular head of pectoralis major. And those signs result in, according to the involved muscles, winging of scapula due to weakness of serratus anterior and trapezius, pot belly abdomen due to weakness of abdominal muscles, exaggerated lumbar lordosis due to weak extensors of the trunk. The patient attempts to prevent himself from falling forwards by the effect of gravity. Waddling gait due to weakness of abductors of the hip, gluteus medius and minimus. Gower sign: characteristic manner in getting up from the floor due to weakness of gluteus maximus. The patient climbs himself. Then we have Duchenne's muscular atrophy. It's caused by mutation of genes which encode dystrophin protein located on the short arm of X chromosome, starting at birth and usually manifest by 3 to 5 years with history of frequent falls. Full lordotic posture develops at 6 years, and by 12 years the patient is wheelchair dependent. Pseudohypertrophy is the feature. Patient usually die in between 16 to 18 years due to fatal pulmonary infection and respiratory failure from paralysis. Cardiomyopathy and heart failure not a common cause. Aspiration of food or acute gastric dilatation. Becker's muscular dystrophy, same as Duchenne muscular atrophy, but mild. Onset is at 5 to 15 years. Patient may survive up to the 4th or 5th decades. Pseudohypertrophy in calves is early and the patient can walk beyond the age of 15 years. Investigations: creatine and creatinine in urine. Normally creatine is absent from urine and creatine is present. In myopathy, creatine will appear in urine and creatinine will decrease because the diseased muscles can't metabolize creatine into creatinine. Number 2, creatine tolerance test. Administration of 2 gram creatine by mouth. Excretion of excess amount of creatine in urine, denoting inability to retain creatine and inability to convert it into creatinine, which means myopathy. Serum enzymes increase CPK, aldolase, and transaminases due to degeneration of muscle fibers. EMG, diminished amplitude and duration of motor units. Early interference pattern. Muscle biopsy, this is the gold standard for diagnosis. Degeneration of muscle fibers and its replacement by fibrous and fatty tissue. Treatment of progressive muscular dystrophy. It cannot be cured, but supportive treatment is used. Physiotherapy rehabilitation, cure against pneumonia, bed sores, DVT. Vitamin E helps to retain creatinine in body. Corticosteroids, recently used, increases muscle strength, muscle mass, and decrease the progression of the disease. Consider genetic counseling for prophylaxis. Channelopathies or familial periodic paralysis syndrome. Channelopathies are ion channel disorders of muscle cells, autosomal determined trait caused by mutation in a muscle voltage gate calcium or potassium or sodium channel genes. Familial periodic paralysis syndromes, they are acute recurrent attacks of weakness resulting from alteration in the serum potassium levels of familial origin. We have 2 types: hypokalemic periodic paralysis syndrome and hyperkalemic periodic paralysis. Hypokalemic, it occurs in the first or second decades of life. Triggers: rest after exercise, carbohydrate load. Onset: usually awakening in the morning. Clinical picture: weakness starts in lower limb and rapidly becomes generalized. No bulbar or respiratory affection. Duration: the attack takes hours to days. Ectal potassium is less than 3 milliequivalent per liter. Response to potassium improves the weakness. Treatment: acute cases, potassium chloride IV drip with ECG monitoring. Prophylaxis: acetazolamide 250 mg per day. Low carbohydrate and high potassium diet. Hyperkalemic periodic paralysis syndrome, it starts in first decade of life. Triggers: cold, rest after exercise, high potassium meals. Onset: immediately after exercise or cold. Clinical picture: weakness is starting in the lower limb and rapidly becomes generalized, myotonia in some cases. Duration: hours. Ectal potassium more than 4.5 milliequivalent per liter or normal level of potassium. Response to potassium triggers weakness. Treatment: for acute cases we give calcium gluconate IV drip or glucose plus insulin drip. Prophylaxis: thiazide diuretics. Other channelopathies include myotonia congenita, Becker's and Thompson's, Anderson syndrome, malignant hyperthermia syndrome, and stiff person syndrome. Myotonic phenomena: myotonia is persistent involuntary muscle contraction after cessation of voluntary effort, delayed relaxation after voluntary contraction. If the patient clenches his fist, he cannot open his hand. Mechanical contraction, tapping on the senar eminence or tapping the tongue. Electrical contraction, 2 to 3 milliamperes are sufficient to produce contraction, while in normal cases we need at least 6 milliamperes. It's improved by repetition of movement. Warmth: calcium, quinine, and prokinamide. Worsened by cold, potassium, and prostigmine. We have 2 types: myotonia atrophica, myotonia congenita, which is Thompson's disease. Myotonia atrophica, it's autosomal dominant, males more than females. Clinical picture: gradually progressive condition, usually become apparent in the 3rd or 5th decades. Progressive muscle atrophy and weakness, especially in the facial muscles, sternomastoid, muscles of mastication, distal muscles of the limb. Dystrophic changes include cataract, frontal baldness, esophageal dysfunction and aspiration, cardiomyopathy, and conduction defects leading to sudden death. Small pituitary fossa and hypogonadism, glucose intolerance. While myotonia congenita or Thompson's disease Isolated autosomal dominant in females more than males. Clinical picture mild form but apparent in the first and second decades of life. Pseudo hypertrophy in all muscles of the body and no dystrophic changes or ECG changes. Other rare myotonias include myotonia acquisita and myotonia paradoxica. Treatment phenytoin is preferred. Others may be used such as procainamide, calcium gluconate, and potassium exchange resins. Myasthenia gravis or primary myasthenia. It's a disorder of neuromuscular junction characterized by easy fatigability and progressive inability to sustain a maintained or repeated contraction of striated muscle. Etiology and pathophysiology. Formation of T-cell dependent autoantibodies IgG against nicotinic acetylcholine receptors, leading to decrease in their numbers in the postsynaptic membrane of motor end plate. And some authors consider that the cause of this decrease due to accelerated turnover of acetylcholine receptor by rapid endocytosis of the receptor, or blocking active sites of the acetylcholine receptor, or damage in the postsynaptic muscle membrane by antibodies in collaboration with complements. Thymus appears to play a major role in this process. It's abnormal in 75% of the cases, 65% due to hyperplasia, and 10% thymoma, composed of muscle-like myoid cells with acetylcholine receptor on its surface, which serve as a source of autoantigen and triggers autoimmune reaction. Clinical picture: incidence female to male is 3:2. Peak females in the 2nd to 3rd decades, while males 5th to 6th decades. Onset, gradual onset, progressive course. Symptoms: easy fatigability, progressive skeletal muscle weakness on repetition of movement. Diurnal variation: the motor power is good in early morning and worse at the end of the day. Clinical patterns: we have generalized ocular and bulbar. Generalized characteristic: descending march course, usually starting extraocular muscles in early course. Hanging jaw. Facial muscles expressionless appearance. Bulbar muscle affection, tetrad of bulbar symptoms. Weakness of neck muscles leads to lolling of the head. Lump muscle affection, starting by upper limb before lower limb, proximal and asymmetric in nature. Despite limb weakness, the deep tendon reflexes are reserved. Ocular myasthenia gravis, extraocular muscle involvement leading to intermittent ptosis and diplopia, especially at night. This is the most common mode of presentation. Bulbar myasthenia gravis, affection of bulbar muscles leading to tetrad of bulbar symptoms, dysphagia, dysarthria, dysphonia, and nasal regurgitation. Investigations: clinical tests, pharmacological tests, lab tests, and other tests. Clinical tests: induction of fatigue by repetition of movement, weather, ice pack test, ice over lead, leading to ptosis and diplopia in ocular myasthenia gravis. Warmth improves neuromuscular transmission. Walker's test, applying sphygmomanometer cuff to the arm and raising pressure above systolic pressure. Ask the patient to do rapid repetitive movements with his hand till exhaustion occurs, then release the cuff. If the case is myasthenia, paralysis occurs within 10 seconds. Lab test: anti-acetylcholine receptor antibody assay, present in 90%, give sure diagnosis, but it cannot exclude the diagnosis with its absence. Anti-MuSK antibody assay or anti-muscle specific kinase antibodies, present in 50% of cases with negative anti-acetylcholine receptor antibody, rarely present in positive anti-acetylcholine antibody. Pharmacological test: penicillin or hydrophonium test. Short-acting cholinergic drug. We inject 8 mg after 1 minute. The ptosis and fatigue will disappear if the case is myasthenia. Other tests: EMG, repeated stimulation, progressive decrease in the amplitude of the compound muscle action potential. Radiological: plain X-ray, CT, MRI, isotopic scan in suspecting thymoma. Muscle biopsy: increased lymphocytes. Treatment: anticholinesterase drugs, pyridostigmine or neostigmine. They act within half an hour with duration of 4 hours. Corticosteroids indicated if failed, controlled by pyridostigmine. Start with a certain dose and gradually increase it until it reaches maximally 60 mg per day. Immunosuppressive drugs: mycophenolate mofetil, the most preferred, and you can give cyclosporin, azathioprine, cyclophosphamide. Thymectomy indicated as soon as possible in patients from puberty to 55 years old. An antibody-positive patient with generalized symptoms of less than 7 years duration. Prognosis: 85% of the cases experience improvement in symptoms. The patient with MuSK antibody positive may not improve. Plasmapheresis, removal antibodies from the blood. 5 exchanges, generally administered over 2 weeks, used as temporary measure in myasthenia crisis or preoperative preparation for thymectomy. IVIG, alternative to plasma exchange in treatment of myasthenic crisis, 400 mg per kilo per day for 5 days. Improvement occurs in 70% of the cases. Secondary myasthenia secondary to known cause, bronchogenic carcinoma, polymyositis, SLE, manifested by weakness, mainly proximal, with loss of tendon reflexes and cardinal signs. Unlike primary, weakness improves with sustained or repeated exercise. Reflexes reappear after exercise because this will lead to squeezing of the acetylcholine receptors and release of the stored acetylcholine there into the neuromuscular junction. But you need to know a very important difference, that the generalized myasthenia gravis or primary, we have limb weakness, but deep tendon reflexes are preserved, while they are lost in the secondary type. The secondary type doesn't have marching course and it doesn't respond to prostigmine, but it responds to guanidine HCl or 3,4-diaminopyridine, and that's why they are used in their treatment. Motor neurone diseases, group of neurodegenerative diseases of gradual onset, progressive course, affecting motor system only, systemic disease involving upper motor neuron, lower motor neuron lesions, or both. Clinical picture: age, middle and old age, sex, males more affected than females, onset and course, gradual onset and progressive course, upper motor neuron affection. At level of spinal cord, it's called lateral sclerosis syndrome. Spastic quadriplegia if the lesion occurs above level of C5. If at C5 or below, then it's called spastic paraplegia. If the lesion occurs at the level of brainstem or cerebral hemisphere, it leads to pseudobulbar palsy syndrome with bulbar symptoms: dysphagia, dysarthria, nasal regurgitation, hoarseness of voice. Spastic quadriplegia, exaggerated jaw reflex, palatal and pharyngeal reflexes, emotional and mood changes may be present. If the lesion is above the bones, then make sure that you have exaggerated jaw reflex. Lower motor neuron affection, affecting anterior horn cells and spinal cord. In the anterior horn cells, it's called progressive muscular atrophy, affecting mostly anterior horn cells of lower cervical and upper lumbar regions. Gradual lower motor neuron weakness with fasciculations, starting in the upper limb, especially in the hands, forearms, and shoulders, later on affecting lower limb to much lesser extent. In the cranial nerve nuclei affection, it's called true bulbar palsy, characterized by bulbar symptoms previously mentioned, absent palatal and pharyngeal reflexes, the tongue is wasted, showing fasciculations, no quadriplegia, and no emotional changes. Then we have combined lower motor neuron and upper motor neuron affection. It's called syndrome of amyotrophic lateral sclerosis. In the upper limb, we have weakness associated with wasting and fasciculation, lower motor neuron, as well as hypertonia, hyperreflexia, upper motor neuron, and this is called tonic atrophy. In the lower limb, weakness with signs of upper motor neuron lesion, which may be with minimal fasciculations if lumbar anterior horn cells are affected. You need to know very well the name of the syndromes. Syndrome of lateral sclerosis, upper motor neuron affection at level of spinal cord, pseudobulbar palsy at level of brainstem or cerebral hemisphere, progressive muscular atrophy, lower motor neuron affection in the anterior horn cells, true bulbar palsy in the level of cranial nerves nuclei, amyotrophic lateral sclerosis if combined, and tonic atrophy. This is the affection of the upper limb. Management, currently untreatable, but we may give in the amyotrophic lateral sclerosis riluzole 50 mg. And then we have wasting of small muscles of the hand. They are supplied by C8 and T1 spinal segments, and they are affected in those cases anterior horn cell regions, anterior roots and spinal nerve lesions, lower brachial plexus lesions, peripheral neuropathy, and others. Others include arthritis of the joint, scleroderma, dermatomyositis, distal type of Gower myopathy, myotonia atrophica, orthopedics such as Volkmann's ischemic contracture, disuse atrophy in long-standing upper motor neuron lesion, peripheral neuropathy, all causes of mono and polyneuropathy, carpal tunnel syndrome, wasting of thenar and hypothenar muscles, anterior roots and spinal nerve lesion, whether it's cervical vertebrae from spondylosis, Pott's disease, tumor, fracture, dislocation, or pachymeningitis cervicalis. Then we have lower brachial plexus lesion, pancreas tumor, enlarged cervical lymph nodes, thoracic outlet syndrome, subclavian artery aneurysm, Dijon clumps paralysis secondary to birth injury. Cervical rib leads to decreased radial pulse on the arm and neck stretch at Sun test. Wasting is with paresthesia over the ulnar side of the forearm and the hand. And finally, we have anterior horn lesions, intramedullary lesions, syringomyelia, lower cervical tumors, motor neuron disease, anterior spinal artery occlusion, acute onset, regressive or stationary course. Both upper limb show flaccid paralysis and lower limb show spastic paralysis. There is dissociated sensory loss. Touch and deep sensations are intact. Transverse myelitis, C8 and T10 segments. Poliomyelitis, starting at 6 months to 2 years with acute onset, regressive or stationary course. Wasting is asymmetrical, affecting lower limb more than upper limb with no sensory changes. And this concludes our chapter whether for myopathy or peripheral neuropathy.